everyone, and welcome to Lying Around Connecticut with Carol and Harry. I am Carol Kearns. My husband, Harry Shue, is our co-host. Our mission for the show is twofold: to provide information about Connecticut Lions events and to showcase the many different organizations and causes that Lions support locally, regionally, and internationally. Harry?
Good evening and welcome. Please consult our website at www.lions23b.org or your district spirit for more information on coming events.
Hello, everyone, and welcome to Lying Around Connecticut with Carol and Harry.
Welcome back for more of Dr. Egils Bogdanovich, who's giving us another wonderful update on diabetes and what's new. So, on with the show.
En avant.
Is, replacing insulin itself. So, I mean, if you look at type 2 diabetes, at some point, as this insulin secretion drops off, your sugars continue to go up, and it doesn't matter what kind of pills you're taking because you really need to replace some insulin as well. It may not mean that you got off the pills, you still have that resistance here, so we still want to use some medications for that. But this is when we add at least a little bit of insulin, like basal insulin. Because we know that insulin secretion drops. Remember that British study, the United Kingdom prospective study? Well, they actually measured insulin secretion. And when they were diagnosed, the guesstimate was that you had lost about 50% of your cells in the insulin. Gradually over time, you put the line down here, by 15 years, everybody's going to need some insulin. So, when somebody's newly diagnosed with diabetes, I like to say, you got some good news and bad news. The bad news is you're going to need insulin. I don't think it's bad. A lot of people think it's bad. The good news is I think you're going to live long enough to need insulin. So that if anybody in this room has type 2 diabetes and is somehow thinking, I don't want to go on insulin because it's the end of the road, it's admitting failure, it's just, that's the way the disease goes. So pancreatic poop out is a scientific term, and it unfortunately happens. Now, sometimes this slope is really drawn out. I'm looking at some people in the room where I know that they're going like this, but most of the time, on average, it's about 5%. So how do we give insulin? We try to mimic Mother Nature as much as possible. If you look at Mother Nature is in the yellow here. Overnight, you're always making a little bit of insulin. Towards the morning, you start making a little bit more. Then, with the meal, you make a big spike here. With the lunch, a little bit smaller. Dinner, same spike there. And when we get our insulin, we try to mimic this basal amount of insulin, and then we try to mimic this bolus insulin here. So we're not going to go into all the insulin specifically, but suffice to say, basal insulin, these, means something that just gives a little bit all the time. In fact, many times for type 2 diabetes, that's the first insulin we add. We continue the pills, we just give your pancreas a little bit of help by giving a little trickle of insulin the whole time. Bolus insulin is what you take for a meal to mimic that spike. It doesn't last long, it's about 2 to 4 hours, but to mimic that spike, sometimes with the biggest meal, which, take a guess which meal you need your bolus insulin best, most of. Is it breakfast, lunch, or dinner? Yeah, breakfast. Good. It's so interesting. The breakfast, because there are a couple of hormones that are being secreted right around here. We call it the dawn phenomenon. It's cortisol and growth hormone. But the other thing is that in this country, most of us eat carbs for breakfast. And so when we add that first shot of mealtime insulin, usually it's for breakfast. And there's a lot here, and there's even one that's inhaled. All of them are pretty similar in action. In the old days, we used this regular, we now call it regular human, which is a little bit slower in action. But the rest of them are very, very equivalent. This is brand new. It's called FAST. Stands for faster acting insulin aspart, or faster Novolog, which it goes into the circulation about 4 to 5 minutes faster. Doesn't sound like a lot, but 3 meals a day, a lot of days, it may make a difference as far as the time that you're in range. So why do we show Reese's peanut butter cups in a diabetes car? And that's because this brings up, does anybody remember the commercials for Reese's peanut butter cup? You got your peanut butter on my chocolate. You got your chocolate in my peanut butter. Well, we now have these drugs that are combination drugs with insulin and a GLP-1. So Zoltify is an insulin, it's called Tresiba, with a GLP-1, it's called Victoza. Soliqua is Lantus, plus a GLP-1 called Lixisenatide. So is this for everybody? No, but sometimes you can get it with just one shot and take a couple of medications at the same time. So this is your first quiz. Most common cause of death in diabetes is end-stage kidney disease, cancer, heart disease, or skateboard accident. Heart disease, there's still what we call residual risk. We've come a long way. The statins that treat cholesterol, blood pressure treatment, all those things have decreased cardiovascular disease in diabetes. And it's come down from the 1990s to the 2000s now, but there's still this residual risk where if you have diabetes, you have about 8 times the chance as if you don't have diabetes. Since about 2008, there have been a number of cardiovascular studies. Does anybody remember Avandia? Was anybody on Avandia? So after Avandia got in trouble for what was thought to be an increase in heart disease, as it turned out, it was clear. Nevertheless, when the FDA looked at it, it said that after 2008, any drug that was going to be approved for diabetes had to show not only that it worked to lower hemoglobin A1C, to lower sugar, but that it had to actually not kill you. So by that they meant, I'm kidding. I think that there are other causes of death that might be bad also. I'm sort of flippant about it, but it had to be 1.8 relative risk, meaning that it couldn't increase compared to placebo in the cardiovascular events by 80%. And what they looked at was cardiac death, non-fatal MI, and non-fatal stroke. It's called the 3-point major adverse cardiovascular events. So since that time, there have been 25 studies on drugs for diabetes. A lot of them have been neutral. Nobody's ended up killing more people, so the FDA wouldn't approve them. But some of them serendipitously showed they actually decrease your chance of getting a heart attack, decrease your chance of having a stroke, decrease your chance of having a fatal cardiac event. First one was liraglutide, which was in the LEADER trial, which is the brand name Victoza, and they saw that the reduction was 13%. So a 13% reduction over about 6 years or so, a little bit less than that, 5 years, compared to the placebo. It actually is now used in patients to prevent heart attacks or cardiac events. The second one was a pill. This is empagliflozin, the brand name is Jardiance. And this EMPA-REG trial showed a nearly 40% reduction after 4 years compared to placebo, which meant other drugs. So you see this differential starts right off the bat, which is pretty interesting. And we've seen this in a number of other pills in this sweet pea class. And the last one, which was published about a month ago, is sort of interesting to me. And the reason it's interesting is that these patients, only 30% of these patients with diabetes had known heart disease. 60% of them didn't know they had heart disease or didn't have heart disease, let me put it this way. And they were treated with this weekly incretin, as Trulicity or liraglutide. And this was recently published, and you see that there's a 12% decrease in cardiovascular death, non-fatal heart attack, non-fatal stroke. So now we're starting to look at these guidelines for diabetes. It's not just what lowers your blood sugar. It doesn't lower your blood sugar and also decrease your risk of having a cardiac event. And if you look at the guidelines from the American Diabetes Association, we're not going to go into this, but suffice to say that there's actually a tree here if you have established atherosclerotic cardiovascular disease or chronic kidney disease, which is the other thing to worry about. We go with these classes of medications right off the bat. Hypoglycemia. Has anybody ever had a hypoglycemia bout? So my sister used to say, you lower just stupid. Yeah, so hypoglycemia is low blood sugar. And unfortunately, it's part of insulin therapy. You're on insulin, part of some other oral agents also. And there are a lot of symptoms that happen when you're hypoglycemic. I'm not going to go into these, just suffice to say that there are two groups of symptoms. One group are the adrenaline ones. That happens right off the bat. You get shaky, sweaty, feel tingly, dry mouth, pupils dilate, sort of like you just saw a ghost. It's good to have that. People complain, I don't like that feeling, but it's good to have it because if you don't get it, the first thing you get is the brain symptoms, the neurologic symptoms, the neuroglycopenic symptoms. And those are, in an expression, you lose fourth grade. So judgment goes here. In fact, Elliot Jocelyn noted that when insulin was first discovered, 2 years into it, he's using it in Boston. He says, with Freddie, no reaction occurred with blood sugar of 60. With Alice, none when it was as low as 40. Dangerous hypoglycemia occurred with Alice. And hypoglycemia definitely affects how you treat your diabetes. If we look at, for those of you that have diabetes, you know that the symptoms, the adrenaline symptoms don't feel good. I always say you get an adrenaline hangover. You get that shaky and sweaty, even though your sugar is back to 120, you just don't feel right for a couple of hours. Some people take days off. There's a lot of productivity loss regarding hypoglycemia. Obviously, the anxiety and the fear of future hypoglycemia will affect you as well as your family. If you've ever seen a family member with hypoglycemia, those of us that have diabetes, it's not a big deal. We wake up and say, what's everybody doing here? What's that anything? But for the family members that are watching you shake and sweat and have a seizure, it's pretty traumatic. And of course, if you had a low, it's going to affect what you do. About 50% of people that have had severe lows manipulate their insulin dose because of fear of hypoglycemia. So there are certain jobs where you definitely don't want to become hypoglycemic. Yeah, so the newest thing in preventing hypoglycemia is continuous glucose monitoring. Some of you in this room have them. It's a little filament under the skin. But, it's not that long ago that we didn't have any way of monitoring your glucose. We had urine tests in the early 20s, and that lasted until about 1980 or so, when finger stick monitoring came in onto the scene. And this is the Ames glucolance. So you cock this, you put a lancet in there, put that against your finger, stare at it for a few minutes, and then press the button, and boom, that came down. Pretty barbaric way of making blood, but this is what we used. So when I was diagnosed, they had to order this from England. And it took a couple of weeks to get this device. The early machines, you had to put the blood on it, wait a minute or so, blot it, sometimes rinse it, wait another minute, put it in. Our machines today are 5 seconds and you have the glucose. But the thing about that was that some doctors didn't think that it was a good idea that patients will hurt themselves if they actually know what their blood sugar is. So that was sort of the second revolution in diabetes care. The third really is continuous glucose monitoring. This is not the most accurate way because does anybody wash their hands when they do their finger stuff? That's nothing that. But it really does make a difference. It really does make a difference. So if you get a funny looking sugar that doesn't match how you feel, wash your hands and do the glucose again. Because all it takes is a little bit of milk or jam or pancake syrup on there, and you can make that sugar look a lot higher than it really is. So this is sort of to introduce continuous glucose monitoring. With a finger stick, we see that number, but we don't know if it's going up, if it's going down, if it's going straight across, which way the ball is going. And you can see a lot from putting on a continuous monitor that you don't see with an A1C. Now, a hemoglobin A1C of 7.8, that's not terrible. And that's one patient that has a hemoglobin A1C of 7.8. But this is a patient with a hemoglobin A1C of 7.8 as well. Which one would you rather be? I mean, obviously the first one, because patient number 2 has this high variability. So the patient's got unrecognized hypos, or maybe recognized, but didn't woke them up, and then hyperglycemia and other kinds of things. Today, we've got a few different ways of doing continuous glucose monitoring. Dexcom G5 and G6, Freestyle Libre, and Medtronic Guardian Connect. Those are the three big ones. Freestyle Libre, last year, Theresa May, before Brexit blew up, was in the press wearing her Freestyle Libre. She got in a lot of trouble for that because the national health system doesn't cover for people with diabetes. But she had one. So you can be sure that they started covering it pretty soon after this. There's actually another one introduced this year. It's called Senseonics Eversense. And this is a little pellet the size of like a Tylenol capsule that's actually implanted under the skin. Stays there for 3 months, soon to be 6 months, and transmits to a little patch that you put over it that goes to your phone. I don't know if I'd want to have something under my skin, but some people, this is a good way of ensuring that you're using it because it's really under the skin. So the sensors are the size of an eyelash that go under the skin. And here's just an example of a continuous glucose monitor. Here's our type 1 diabetic, who's 18, A1C is 7.2, which is excellent. Here's what the 5-day sensor modal day looks like. So these go from midnight to midnight here. So this is breakfast here, big spike. Remember we talked about breakfast, what happens after that. But this is the overnight, which is the first thing we look at with these continuous glucose monitoring. Tracings. And you see that most nights it's coming down like 100 points. So if he doesn't go to sleep with a 200, he's going to be hypoglycemic. For example, this day, he goes to sleep with 100 and is less than 40 for most of the night. Flatline in this is less than 40. It's not going to be good. It's generally not good to be flatline in anything in medicine. But in this case, it's a glucose of less than 40. So looking at patients that are wearing continuous glucose monitor, it doesn't matter if you're high A1C or low A1C. You know, obviously if your A1C is high, over 9, you're going to spend a lot less time high. You're going to spend a lot more time in that target range. And you actually spend less time low. If you're starting off with a great A1C, you still need one of these. Because you're going to spend 46% less time in that severe low range that we consider less than 55. So Medicare now approves continuous glucose monitors if you, doesn't matter if you have type 1 or type 2 diabetes, but you have to be checking at least 4 times a day at home, and you have to be taking insulin, 3 injections or more per day, multiple insulin injections, and have a plan that requires frequent changes based on readings. We all have that plan. You don't even have to teach somebody what to do with this. If you put it on, A1C gets better because you're mindful of what the sugar is. It's like doing your finger stick every 5 minutes, but more importantly, it gives you arrows. It's going up, going down, staying the same. You can even talk to it. Hey Siri, what's my sugar? Cool. I knew it was good. I wouldn't have done that. So this sort of brings up the concept of beyond A1C. You know, we've been looking at A1C all this time. I'd like to say, let's look at the quality of the A1C test. You know, these are all hypothetical patients with an A1C of 7. In this 3-year, that's the one you want to be because it's 100% time in target range. But in 1 year, there's a marked high, a marked low, and you still have that A1C of 7, but about 60% of the time you're high, about 24% of the time you're very low, and very small percentage of the time it's actually in range. So A1C doesn't fluctuate. What we look at now is these continuous glucose monitor tracings. This is an example of one. We look at how much time is in that target range. I put down here what our goals are. We have 70 to 180 is our target. Anything over 70% means you're going to have an A1C of 7. Then we look at how much time is spent very low, less than 54. We want less than 1% of the time there, and that's 0.1 there. And then we can look at what the last 14 days are. And the average is the orange line here, and the blue is the middle 50 percentile, and the dashed lines are the outliers. So this is a pretty good tracing, isn't it? 126 is the average, 80% time in range, very little time spent. So how do we treat that hypoglycemia? The only other thing that's new this year is a way of treating hypoglycemia. In general, we treat with carbohydrates. So we teach the 15-15 rule. If your sugar's low, 15 grams of carbohydrates, 15 minutes later, check your sugar again, and repeat if you're still low. The other way is glucagon. Has anybody ever been injected with glucagon in the room? Or injected somebody else with glucagon? It's nasal glucagon powder. So I think in the future we're going to change everybody from injections over this powder. It comes in this little thing, you stick that up your nostril and just press that. You don't do it yourself because you wouldn't want to do it yourself. You just eat, you can do it yourself. But if spouse, kid, whatever it might be, it's stored at room temperature, you just open it up and squirt it up there. It doesn't matter if the patient's conscious or unconscious. It doesn't matter if they have cold or sniffles. It works pretty as quickly as a subcutaneous. Yeah, it's available now. You know, probably need a prior authorization. It's literally like a month or 2 months ago. You need a prescription. But I think that this will, a lot of people on insulin, aggressive insulin therapies, their families don't have glucagon. It's just for some reason we forget to do it. It's our fault, you know, the providers. But since this came out, I think we're becoming a little bit more likely to recommend that you get glucagon because the injection kit's perfect. I mean, you know, part of that 15 grams of carbohydrate. You know, a lot of people use little cherry gels, you know, the single use, you break off the top and put the gel in. A cheap way of doing that is using cake frosting. You know, the tube's $1. Pick a flavor you like. You can actually close it up so you can actually dose how much you need. Or
little signs in the glucose things around the house because my caregiver came 15 minutes early and found me with a blood sugar doctor himself. Called the ambulance, called my doctor and said she said some marmalade on something in her mouth.
Yeah. We've got, in my house I've got a smoker's jam, and it's mine. It's in the refrigerator. Nobody uses it. Just a tablespoon is like 30 grams. If you're conscious, that's great. But if you're unconscious, you have that treatment. I mean, the average hospitalization, the average ER visit ranges from $1,300 to $7,000. So it depends on whether $1,300 is like you go in there and they give you a tuna sandwich and that's it. And send you out. You know, whereas if you're hospitalized with a complication, in the elderly, hypoglycemia can precipitate heart problems. So there's a lot of indirect costs. Continuous glucose monitoring is Jackson, Wyoming. And I wanted to just say one word about type 1 diabetes. I know most of us here have type 2 diabetes, but type 1 diabetes, you know, this is type 2 diabetes. You got 12 classes of medication. This is type 1 diabetes. Wow. You know, we've got insulin, and we've got this thing called pramlintide, which nobody uses. So really, it's just insulin. You know, we're almost 100 years into this, and we have not figured out an additional treatment for type 1 diabetes. And if you look at type 1 diabetes right now, overweight is becoming a problem. You know, the most recent numbers, about 60% of people with type 1 diabetes are overweight or obese because we live in America just like everybody else does. So this was sort of interesting this year, a study showing empagliflozin, which is one of those sweet peas, in type 1 diabetes, 3 different doses, lowering the hemoglobin A1C, but more important than just lowering A1C, the weight was reduced, blood pressure came down, on continuous glucose monitoring, an extra hour or so was the time in range. To me, the most important thing is satisfaction increased by 2 points on this questionnaire. And that's the degree of satisfaction improvement from when we went from NPH insulin to Lantus. I don't know if you guys remember, that was 2000. That really revolutionized type 1 diabetes. But unfortunately, the FDA met today and did not approve the drug for use in its current status. Hopefully, hopefully it'll come back. I was hoping when I put the slides in that say we now have a new treatment, but not yet. So we're going to wear this every day. Everybody's seen the slide in diabetes talks. saying this was the first insulin pump. That actually wasn't. This was an artificial pancreas. This guy, Arnold Kadish, figured out a way of measuring glucose in here and having an algorithm and infusing insulin. I mean, it's just funny to see. This actually is one of the first artificial pancreases. This was biostat, where the glucose was measured through one line and insulin was infused through another line. And right now, we're getting closer and closer to closing the loop, so to speak. This is Billy Woods. He knows I use this slide. He's proud of it. He was a guinea pig in the artificial pancreas project, so he has a couple of Dexcoms plugged in here, or somewhere on the other side, going to his phone, deciding when to give insulin, when to give glucagon. So as glucose came down here, give a little glucagon boluses here. As the glucose went up, insulin boluses in the blue here. Keep the sugars in between. Now we've got a couple of devices that are approaching that sort of hybrid closed loop. The 670G by Medtronic, which uses a sensor, and the pump, which gives a little bit extra infusion. Sugar is high, puts it on suspended, glucose is low. Our newest closed loop is the tandem with the Dexcom continuous monitor. Here's the Dexcom going to your phone, just like Siri there, and also going to the pump. So you see in the red here, as the glucose is dropping down, on the red it means it's suspended. As the glucose started to come back into normal, it started infusing again, and you get the message, or you get the idea. It suspends when it is low. And then this pump is going to start giving more insulin when it's high in the next week, in the next few months. So this is Boston, head of the trials, and brings us back to Elliot Jocelyn, the patient who knows the most, lives longest. It's the theme of diabetes, or World Diabetes Day this year. Diabetes concerns every family. Don't beat up your diabetic family members and support. And the other thing is, anybody that you know at work, school, wherever it may be, that's got excessive thirst, frequent urination, fatigue, blurred vision, slow healing wounds, tingling, numbness in the feet, haven't checked their sugar. Because there are a lot of patients out there, up to a third of those patients with diabetes, that are walking around. On every November 14th, we celebrate Sir Frederick Banting and diabetes. And hopefully we won't have to be doing these World Diabetes Day programs in a few years from now. Thanks. Any questions?
Hello again, everyone. Hasn't this been a wonderful evening?
It really has. Dr. Bogdanovich always does a great job. He is so knowledgeable about diabetes. So that'll do it for this episode of Lying Around Connecticut with Carol and Harry. Bye now.
Bye-bye.
We hope you enjoyed our show this evening. Tune in next week for another Lying Around Connecticut with Carol and Harry. Good night.
Bye-bye.